Good morning, everybody. Welcome back to another edition of the Department of Medicine's Grand Rounds. Today, we have Dr. Elvin Geng speaking with us today. He is from the Division of Infectious Disease, and he's also the director of the Center for Dissemination and Implementation within the School of Public Health. So without further ado, I will hand it over to Dr. Geng.
Okay, good morning. So I'm delighted to have the opportunity this morning to talk to you about implementation science. My name is Elvin Geng, and I am delighted to get into things here with you all. I think we'll dive right in, and perhaps at the end we'll have an opportunity for a little bit of discussion. I have to say I haven't given that many in-person talks since COVID, but this is a good opportunity to engage not only in a talk, but have the opportunity to have some dialogue. So I think the talk this morning is going to take the form of 5 segments. And I'm going to try to convey the basic premise and the value proposition of implementation science. In the first section, through the looking glass, I'll talk about the motivation for the field. In the second, a different differential. I'll mention how implementation science analyzes problems scientifically. In take 2 and Call Me in the Morning, I'm going to talk about implementation strategies. So in clinical medicine, we have medications and we have devices. In implementation science, we have strategies to try to solve implementation problems. And then in the 4th section, You Want It, You Got It, I'll talk about implementation outcomes, what they are and why it's important in science looking at problems of implementation to conceptualize and measure those things. Finally, I'll end with an invitation, which is to say WashU is a great place to do implementation science, and whether you're interested in dipping your toe in, taking a deeper dive, or if you're ready to drink the Kool-Aid, we are here to help. So through the looking glass, I'm going to start with a case. It's a simplified case, but one that many of you may find familiar, given that we're on the tail end of a pandemic. So 68-year-old man presents the ER, 4 days of fever, dyspnea, some oxygenation trouble at baseline, but not too bad. A chest x-ray shows some focal pneumonia, but also ground glass. He's got a PCR positive for SARS-CoV-2, is admitted to the floor, starts some medications, gets bacterial coverage, but the next day continues to do not so well, perhaps a little bit worse. And on rounds, many questions come up. So why is this patient worse? When do you consider another medication? Was the patient risk stratified correctly, et cetera? And the case I'm going to make to you this morning is that we normally take a clinical lens, right? And we ask these questions that I just mentioned here, comorbidities, side effects of medications. But we could also look at this through an implementation lens, through why evidence-based interventions that we have in medicine are not used, and analyze the problem from that perspective. It's sort of like this Rorschach test. Is this a rabbit or a duck? I think it depends on how you look at it. It's the same picture. So this gentleman was in fact not vaccinated. So why not? What was going on? Was it access? Was it beliefs? This person actually had a primary care provider, but had not heard from the primary care provider. So should primary care providers be a part of the public health response to pandemics? Is dexamethasone overused in patients with mild disease? And could he have gotten outpatient monoclonal antibodies? And if not, why not? These are all questions about implementation that we can use to examine our problems with health systems and public health. Implementation problems are common. I think I heard an interview where the director of the NIH, a year after vaccines were licensed, said he felt very surprised that only 2/3 of Americans had had 1 dose of any COVID vaccination. But yet, problems with implementation are pervasive. These are some data that I've put together from a number of different sources, but in the United States, probably about half of people with hypertension, the 80 or so million people with hypertension, have controlled hypertension. A good 1 out of 5 have probably not been diagnosed, and the remainder have been diagnosed but are not adequately on treatment or successfully treated. Probably about a quarter of people with diabetes in this country are adequately controlled, and a good third are not diagnosed. And in HIV, the field that I work in, probably about half of people are fully controlled and fully benefiting from the medical treatments for HIV, and a good 15% to 20% may not even know that they have been diagnosed. So these implementation problems are pervasive and they're common. The last time a national survey was done, which is almost 20 years ago now, and I've tried not to, I've stopped using that slide because it's outdated, but Elizabeth McGlynn published in the New England Journal a national survey of how much healthcare Americans receive, how much indicated healthcare. And the answer that she came up with was, it's about 50%. And I think things are better now, but I know that we're not all the way there. So these implementation problems are a threat to population health. And I'm going to use a slightly older example here to illustrate this point. Those of you who are cardiologists here will know much more than I do about the BHAT trial, but in JAMA in 1982, a study was published, a randomized trial that demonstrated beta blockers after MI reduced mortality by about 3% on an absolute risk difference. So, and the endpoint in this randomized trial was mortality alone. I don't think we have that many trials like that anymore. But in 1997, a national survey using Medicare data suggested that only 34% of all persons who had an MI were discharged with a beta blocker. And in fact, in that study, receiving a beta blocker had the same effect on survival as the original JAMA randomized trial. It wasn't until 2007 when Thomas Lee published an editorial in the New England Journal called Eulogy for a Quality Metric, where he describes the fact that most all patients are discharged with a beta blocker after MI, that this intervention that was demonstrated to be efficacious in 1982 was finally widely implemented. And this took 25 years. I don't know that this is a back of the envelope calculation based on the BHAT trial, and in it I simply took the absolute risk difference that was observed in the trial and applied it to the population of people in the United States over those 25 years who had an MI, and using the coverage that we actually saw, the middle bar, beta blockers probably saved about 180,000 lives. But if beta blockers had been instantly, hypothetically, scaled up and used at scale, we could have saved 478,000 lives. So the difference there is almost 300,000 lives. And this is due to implementation. So I think we scaled up eventually, it took 25 years, but we also lost an enormous opportunity during that time to save lives. And this is not specifically, imagine the magnitude of this problem across a number of health problems and health conditions for which we have evidence-based interventions, yet we're not using them to the best of our capabilities and abilities. So this problem of an implementation gap and conceiving of this problem as a scientific problem is now increasingly mainstream. So implementation science, we'll use this definition for the moment, a study of methods and strategies to facilitate the uptake of evidence-based practice into regular use, is supported at the NIH. So this statement from the NIH says, billions of US tax dollars are spent every year on research and hundreds of billions on service delivery. Relatively little is spent on or known about how to best ensure these lessons are learned, that lessons learned from research improve health. And that NIH recognizes that closing the gap between research discovery and clinical and community practice through scientific inquiry is an absolute necessity. Let me ask folks in the audience, if you're familiar with the term implementation science, just show me your hand. I just want to get yeah. So I think most folks have heard of the term, and And I think that it is increasingly catching on. There are journals called implementation science. There are meetings for implementation science, and I think there is an increasing presence of the term implementation science in our mainstream scientific journals. So I guess before I get into a differential, just to say that this is a story that resonates with many practicing physicians. It certainly resonated with me when I was a resident, because I had not heard the term implementation science, but I went into infectious diseases because we had highly efficacious treatment for most infectious diseases, and including HIV at the time. Yet, when I was a resident in New York City in the early 2000s, the hospital still had many, many people dying of opportunistic infections. And to me, that was a conundrum that I wanted to work on. So love it or hate it, physicians practice in an implementing environment. And I think everybody, all the physicians in this room are familiar with it as lived experience. And I think part of what I want to do here this morning is to make the case that it's also an increasing target for science. Okay, so a different differential. So if implementation gaps exist, then how do we begin to study them scientifically? I think this requires understanding why the gaps exist. We need, just as we do in clinical medicine, a diagnosis. So unlike in clinical medicine, implementation science does not yet have a manual of diagnoses. I think the science, our clinical science is much farther along. So, when somebody comes in with shortness of breath and these other symptoms, you can come up with a well-established sort of diagnosis. I mean, there may still be things out there that we haven't diagnosed, but most patients we can categorize. We can't really do that in implementation science yet, but we do have frameworks for helping us unpack and analyze problems with implementation. And I'm just going to go through a couple, there are many, but to give folks a flavor for the kind of thinking and reasoning that we use in implementation science. So this is a what's called a socio-ecologic framework. It's a very simple conceptualization of people as nested within relationships, as nested within systems and organizations, within communities and within societies. And this is very simple, but on some level, very profound, because you can understand implementation problems at each of these levels, and where you start and the assumptions you make about where the problems lie will inform the diagnosis that you come up with. So I don't know if folks in this room know, but in almost every survey done after COVID vaccinations were marketed, hesitancy in Germany and France was greater than in the United States. But in the United States, we vaccinated less people than in Germany and France. The same surveys, same instrument questions, done multiple times by multiple groups. And so when we think about that individual who was not vaccinated, a lot of times our initial reaction is that it must be the individual, that person's beliefs, that person's motivation. They're not motivated enough to get vaccinated. But what those studies tell us is that people exist within systems that influence their behaviors. And if we want to understand implementation, we need to look at beyond the individual. We did some of the medical students here did a very nice survey looking at talking to people who were admitted with COVID a year ago who were not vaccinated and asking them questions. 25% of the patients here said that they were adamantly ideologically opposed to vaccination, but yet in the rest of the patients, there was always some reason. I was going to get it, but I didn't get it because I don't have paid sick leave. So if I felt bad the next day, I wouldn't, I'd give up a day of work. So I kept putting it off, things like that. So there are different levels at which implementation problems can be explained, and we should look at many of those. So diffusion of innovations, I don't know if folks have heard of this. This is a forerunner to today's sort of modern implementation science. It was published by Everett Rogers in 1962. This is the second most cited book ever. It is the 17th most cited scientific publication ever. This book is cited more than Watson and Crick's paper describing the discovery of DNA. So it's also widely applied today. And in it, Everett Rogers talks about why things spread and why things do not spread. And he goes through several different dimensions, but I'm going to focus, he talks about the social systems, communications modalities, but he also talks about attributes of the innovation. So he says 5 attributes of any innovation will have an influence on whether or not they spread: relative advantage, compatibility, complexity, triability, observability. And I bring these up just to say that if we look around in our world today, these ideas are widely used. I might be dating myself a little bit, but I don't know if people remember buying shoes from Zappos. Zappos' claim to fame was that you could return the shoes super easily. You don't have to commit. Just get the shoes, buy them. We'll send them to you. Try them on. If you don't like them, send them back. That is Everett's observation about trialability. People are more likely to take up something if they don't have to commit to it. And in fact, even if you don't like the shoes, I bet you most people did not send those shoes back. So Zappos is making money off of your off of the principle of trialability. I would say if we look at the practice of medicine, do we do that or do we not do that? In the early days of HIV, even up until very recently, doctors often demanded patients to make a commitment to treatment. I won't treat you unless you are committed to treatment. You're going to be on this treatment for the rest of your life. And that scared a lot of people away. People didn't want to start because they were like, I'm scared of taking this, and the idea of taking this for the rest of my life is going to is a scary proposition. It's a let me wait. And yet many people got sick with AIDS while they were waiting for that. So I think that inadvertently we're not always using the theories of spread optimally. Okay, I'm gonna talk about one more and stop. There's, by some counts, 107 of these sort of theories and frameworks in implementation science. Obviously, that's a problem since nobody's going to look at 107 of them or absorb them. So I'm just going to use one other one. This is the COM-B model offered by Susan Mishi. This is a highly cited paper published a few years ago, 5,000 citations. But she basically puts forth that behavior in implementation around an evidence-based intervention can be distilled into the interactions between motivation, capability, and opportunity. And I think that this is an important, very simple set of tools to dissect implementation problems. 15 years ago in HIV, randomized trials were published showing that a medication taken once a day could essentially categorically prevent HIV infection, PrEP. And at the time, people thought, okay, this is it. We're going to end the epidemic. It's going to be great. But 15 years later, very few people use PrEP who need PrEP, and the epidemic continues to rage. And instinctively, physicians that sought to promote PrEP thought, okay, so we need primary care providers to do this. So they need to be motivated. So we need to motivate them. We need to get them excited about this new intervention. Okay, so that didn't work. So then they said, okay, well, primary care providers don't know how to do it. They don't know how to take sexual histories. They don't know how to prescribe PrEP. So let's focus on capabilities. That's not it either. A lot of times primary care providers simply don't have the opportunity. They are inundated with priorities for the 15 or 20 minutes they have with patients. And it's important to consider all of these domains when trying to understand why an implementation problem exists. I'm going to end this section on the diagnosis with an example that I hope might bring this home. So does the diagnosis matter? When you see an implementation problem, is the way that you explain it, how does that influence what happens subsequently? Does it matter? Is it important? And I'm going to say that it is. This is a paper that was published in The Lancet that illustrates how, in some ways, an out of the box, well, it's not really out of the box, but it's a different diagnosis will lead you to a different set of solutions. So this is about antibiotic overuse and overprescription, which is a problem in ID that's widely known. And I'm going tell you a brief story about when I was a resident. There was a ID doc named Dr. K, who was at one of the satellite hospitals where I trained in New York City at Columbia. And he was an infectious disease doc. And literally when he came, when residents saw him, we would run the other way. Because you know, he would be like, hey, Elvin, why is that guy still on antibiotics? And we would be like, you know, you didn't want to see Dr. K because you know you were in trouble. So Dr. K's mental model is that you are not either motivated or capable enough to make the right decision. And if I yell at you frequently enough, you will come to the right decision. Or if I reason with you well enough. But of course, that didn't work. Now, in this paper, Michael Halsworth, who was a speaker here, we invited him to be a speaker at WashU some months ago, and others in the UK came to a different diagnosis and tried a different solution. So they said, okay, actually, you know what? In fact, physicians are actually pretty social animals. And their behavior is often dictated by what they think other physicians around them are doing. So instead of reasoning with somebody about whether or not you need the 12th day of meropenem, these guys simply found the top 20 percentile of antibiotic prescribers in the UK NHS and sent them a letter. And the letter said, here's the normal curve of antibiotic prescription. I just wanted to let you know that you're the top quintile. And you might want to consider that in your future antibiotic prescriptions. And they would show them the prescriptions being written by other physicians in their geographical area so that they felt like, okay, I am sort of out here. And in fact, they did this as a randomized trial, and it reduced antibiotic prescriptions by a modest amount in outpatient antibiotic prescriptions, which on a population level totaled sort of nearly 100,000 antibiotic prescriptions over the course of a year. So different diagnosis, different solution. And I think that implementation science asks us to think using these frameworks and theories about how to understand implementation problems. Okay. Onward. I might have to increase the pace here. I'm already talking as fast as I can, but implementation strategies. So in clinical medicine, we have devices and medications. In implementation science, we have strategies. What are implementation strategies? Well, Enola Proctor, who is faculty at WashU, proposed an underlying structure for essentially all implementation strategies. And there are many, right? So we can do implementation strategies that are around behavior, training, opinion leaders, facilitation, incentives, et cetera. But there's always an actor who takes a set of actions with requisite dose and temporality, which acts on some action target, which is, I conceive of as the capability, motivation, or opportunity to use an EBI, and that results in some behavior change. And these strategies, what are these strategies concretely? Well, I think this slide probably we can just use here as illustration, but for any evidence-based intervention, you can imagine there are many strategies carried out by many actors in the health system, be they nurse managers, clinic directors, physicians, insurers, non-governmental organizations. They can take a number of actions, sort of audit and feedback, offer incentives, et cetera. And all of that is meant to change behavior. So these are implementation strategies. And I'm going to give one example of a very clever implementation strategy that I think has been widely used and continues to show promise with very many different implementation problems in totally unrelated fields as an implementation sort of strategy. So positive deviance. What is positive deviance? Positive deviance is the idea that in any population of units delivering healthcare, it could be a family, it could be a clinic, could be a hospital, could be a system, that there are some that are doing really well, and some that are doing, most are doing, in the middle, and some are doing very poorly. And if you go to the organizations that are doing very well, and you take a deep dive there using mixed methods, qualitative interviews, process mapping, and other things, you can identify the practices that separate them from the other units. And this has certain advantages because number one, the innovation comes from the population. So it's something that's feasible within the population. And number two, the researcher you don't have to sit at home and come up with these ideas yourself. The premise is that the ideas exist, but need to be harvested. And so one of the best known examples of positive deviance actually comes from work done by Elizabeth Bradley about in the sort of MI space, where she and colleagues at Yale identified out of a national registry dozens or hundreds of hospitals that were doing very, very well, and selected a few of them in which to do these interviews. This door to balloon time problem is well known, but what they did was they tried to map the steps by which somebody with an MI gets seen by EMS, brought to the hospital, things are activated, and ends up in the cath lab and has cardiac catheterization. And they identified in each of these hospitals the things that people in the hospitals felt like were most consequential for making that happen quickly. And they published these results in the New England Journal, where this is probably close to 20 years ago now, but they identified several factors that when they put into a model were the most significant. So so they found, for example, staff expected to arrive, that there was an expectation that the staff didn't need to arrive within 30 minutes. That increased the door to balloon time by nearly 20 minutes. They found that the ER calling before patient arrival, calling the cath lab before patient arrival, reduced on average by 7 minutes. That the ER had a single activation call, nearly 15 minutes. That there was a 24-hour attending cardiologist on site, that was another 15 minutes. And the existence of a post-EKG protocol probably had the largest effect here in this observational study by nearly 20 minutes. But these are the kinds of practices that across these hospitals were associated with faster door to balloon times. So this was carried out in 365 hospitals, and subsequently they were a part of a national campaign to implement these particular interventions. I think there's some debate. I talked to Mark Huffman about this yesterday. There's some debate about how much these particular findings can take credit for reducing door to balloon times, but I think it's safe to say that it was a contributor to the fact that over the last 15, 20 years, these numbers have come down quite a bit. So it turns out that as an implementation strategy, positive deviance has also been used in other implementation problems. It's been used to address nutrition in Vietnam. It's been used to address birth outcomes in the Middle East. And so as implementation science develops, we will develop these strategies that I think can be harnessed and used across a wide variety of implementation problems to improve outcomes. Okay, so implementation outcomes, you want it, you got it. So if we have an implementation diagnosis, and then we have treatments, what are the outcomes that we're interested in when we talk about testing implementation strategies? Well, each of these steps, actor, action, action target, can be thought of as a chain of general sort of causal effects within which you could succeed or fail at each of these steps, right? So does the actor carry out the intended action? Does the action have the intended effect on your capabilities and opportunities and what stuff? And I think those things will determine whether or not your strategies work. And more importantly, I think there's an important case to be made that conceptualizing these steps will help advance our science. And I think acceptability, for example, is considered an implementation outcome and has garnered a lot of attention. And this has asked implementation science and health to think outside the box and to draw from other disciplines in which people have been thinking about these things, and we can in using them for health. I'm going to talk very briefly about a research study that our group was involved in, looking at retention in HIV care in Zambia. So in many places in Africa, HIV treatment is free, yet a lot of people don't stay on treatment. And you ask the question, so why? Obviously, people want to be healthy. The treatment is free, so why don't people stay in treatment? So we went to people who had been lost from treatment and tried to understand what it is about clinical care that they value in order to inform the design of future service delivery to meet those needs. And to do so, you can do sort of qualitative interviews, but you can also apply a method called a choice experiment. And this comes from economics and marketing, where you present a person with various versions of a good or service in which the attributes that make up that good or service are scrambled repeatedly. So you ask, do you want to go to clinic A or clinic B? And clinic A has 1 hour of waiting time. It's less than 5 kilometers from your house. You get 1 month of treatment, but the healthcare workers are rude. Clinic B, you have to wait 3 hours, et cetera, et cetera. Healthcare workers are nice. So which one would you choose? By repeating this choice task over and over again, what you solicit from the person is how much quantitatively they want certain things from care and how much they're willing to trade other things for the things that they want. And when we did this in almost 300 patients in Zambia, we found something that I thought was very interesting, which in this case had to do with the importance of the attitude of the healthcare workers. So I won't get into the nuances of this, but basically on this graph, to the right is happy, to the left is unhappy. So the more to the right, the more happier this attribute makes the population. To the left, the more unhappy. So you can see that nice versus rude is worth a lot to people. We always knew that qualitatively, but this is how much it's worth to people. It's worth more than longer refills. So every month versus 3 months to the left. It's also worth, if you add up the kilometers, so that's a very small thing for each kilometer of distance, but it's worth about 40 kilometers of distance for people, meaning that they would travel 40 kilometers further to have nice versus rude staff. And I think that this is the kind of information that can help shape how you design your approach to implementing services. I'm going to spend 1 moment on this trial. So it's always easy to play Monday morning quarterback, and so I want to do this with humility, but there are many, many large studies that do not conceptualize implementation outcomes and do not measure them. And as a result, even though they are addressing implementation issues, fail to shed much light on the scientific value of what they're studying. So this is from a couple of years ago. It's a very, very large trial looking at a package of interventions to prevent falls. So we know that there are evidence-based interventions to prevent falls. And what these investigators did is they bundled them all together. They had them managed by a nurse, and they tested it in a randomized trial of I think close to 8,000 people across 80 sites. And what they found was that it had no effect, contrary to all expectations. The confidence interval crossed 1, not that much so, but nevertheless, they were not able to claim that the study interventions had effects. And which is not as expected, but that doesn't mean that there isn't an opportunity to learn something. So if we go back to using an actor-action kind of approach, this is the strategy that was actually proposed in the study. So they used nurses who were trained. The nurses were supposed to do a standardized risk assessment, come up with an individualized care plan based on that standardized risk assessment, and then work with the primary care physicians to deliver this package of interventions, which then hypothetically would change the patient and caregiving units' capability, opportunity, and motivation, which would change patient behavior, which would reduce falls. But the study actually did not make any measurements upstream of the clinical outcomes. So we don't know to what extent the standardized risk measurements were done. We don't know whether or not this intervention didn't work because the individualized care plans were not implemented, or if protocol-driven care was not carried out. And in fact, a subsequent qualitative study that went back to ask these questions basically found what might be anticipatable, which is that the study interventions were very difficult to implement. So primary care physicians didn't have time to deal with these fall protocols. Also, some of the things had costs for patients. If they recommended certain things, the patients might have to pay out of pocket for those things. And many of those things, obviously, the patients were reluctant to do if they had to pay for it. And finally, there was challenges with rapport. The study nurses sometimes were well received by the clinics, by the primary care physicians, but sometimes they were not. They didn't get along. The primary care physicians felt like they were being told what to do, and they resisted these recommendations. So at the end of the day, I would say when we look at implementation problems, if we understand and measure implementation outcomes, we will learn something from this trial, even if the trial doesn't have anticipated effects. This is not the only trial like this. I think there are many, many highly publicized trials, the Merit trial, for example, for and many others. And I think that there is a huge opportunity here to layer implementation science on to the clinical science that we're doing. Okay. So I think in the last segment here, I've tried to give people a tour of what implementation science is composed of, but the last segment is an invitation. So this is a survey that was done now a few years ago at WashU in the ICTS, about 600 respondents, and on the x-axis is the level of interest on a scale of 1 to 10 in dissemination and implementation research. So among the 600 respondents, the median level of interest was 7, which is pretty high. And you can see here, many people gave it an 8 to 10. But when asked to rate their own proficiency with D&I, you can see that most people put either low or moderate, even among people who had some to high interest. So there's an interest and an unmet need that I think is important for us to try and fill. So did you know that Washington University is the #1 funded and #1 NIH funded institution for D&I research? I actually didn't know that until recently. But if you go to NIH Reporter and you put in D&I and you sort it by or institution, this is what you get. So we are at the top of this funding sort of ranking order. And I think that as the investment in D&I grows at the NIH, there will be opportunities to build on this success. Why is WashU a great place to do implementation science? Well, there's many reasons. One of them is that many of the leading figures of the field, the founding figures of the field, are faculty at WashU. So Ross Brownson over at Brown School, many of you will know Enola Proctor, who directed the Center for Dissemination and Implementation before myself, Graham Kolditz in the Department of Surgery. If there was a Mount Rushmore of implementation science, I think some of our faculty would be on that. WashU is also distinguished by the fact that leadership has invested in implementation research. And I think Bill Powderly, Vicki Frazier, and others, from my point of view, have championed implementation science and allowed WashU to be the national leader, a national leader in this space. For those of you who want to dip your toe in, let me say you could start by having a look at the website. This is the Dissemination Implementation Research website. There's a QR code. Thank you, Jacaranda, for providing that. And it has a lot of information about what we do, what's going on, and a great place to get started. I think, again, for dipping your toe in, I want to put a plug in here for the Center for Dissemination and Implementation. These are my colleagues, Allison King and Byron Powell, who are associate directors, Ginger McKay, who leads an initiative within, and then Ashley Sturm, who's here, is the center manager, and can help coordinate any interest that you have around many of the things that we do. I'll say a word more about that in a minute. Again, if you're dipping your toe in, there's a newsletter. You can contact Ashley. She can put you on it. To the right here are some of our invited speakers. We have a seminar series The names here on the font probably need some revision, but on the top left, Danny Almiral, who is a leading scholar of research methodology around adaptive interventions and sequential multiple assignment randomized trials, was here. Those of you who are versed in implementation science will know we had Carl May, who's a sociologist in the UK, Michael Halsworth on the far left bottom, and various other folks who are leaders, international leaders, have been our speakers. If you're ready to go a little further than dipping your toe in, you can try participating in the Washington University Network for Dissemination Implementation Research meeting. It's a quarterly meeting, it's a half day, but people can come for any segment of that they like. And there are talks about methodology, there are grant reviews, there are works in progress, and a variety of other things that could be of interest. If you're ready to take a deeper dive, there is a consultation service that's provided by the ICTS where you can get one-to-one consultations about your projects with many of the faculty, some of whom are here today. This is a snapshot of some of our consulting faculty, and not all. Catherine Schwartz, who is in the middle there, will coordinates this, and we will be happy to provide a more a deeper dive on this. And for those interested in deeper dives as well, there's a short course in the spring, and there are courses offered through Brown and CRTC that you can get credit for, and a concentration, in fact, within the MSCI. Finally, we also try to convene spaces for collaboration. We had a summer social, we'll have another one, and anybody who's interested is invited. We had our first Enola Proctor lecture this last year, and we have other events where we try to bring the community of people interested in D&I together at WashU to advance the science, and you are all very welcome and invited. So I think that brings us to the end. I want to conclude with one reflection and a story based on a perspective that I wrote a couple of years ago. And thinking about this talk made me realize that there was something else to this story that I hadn't quite put my finger on at the time, but which I'd like to share with you today. But this is a story about when I was attending on medicine not that many years ago at San Francisco General in San Francisco, and there was a patient who was admitted who had acute on chronic renal disease, hadn't been in much care before, and was hyperkalemic. And the recommendation from the renal team was to start dialysis because medical treatment was keeping him kind of out of the immediate danger zone, but still very tenuous. And the patient refused dialysis. The patient adamantly refused to talk about dialysis and simply did not want to have that conversation. So we were at an impasse. And on rounds, we discussed hyperkalemia, cardiac consequences, dialysis indications. And then when we went to the patient, we talked about the dangers of hyperkalemia, and he just didn't want to hear it. So there was a palpable sense of frustration, and in the story, I think what we did was, we talked about the case, and then in the afternoon, I was supposed to give a talk to the residents, and we were going to talk about antibiotics or something like that, but instead we talked about implementation science, and we talked about the kinds of scientific insights that help us understand how to interact with patients. So things like social proof, right? Like the idea that people turn to other people like themselves in moments of uncertainty. When they don't know how to deal with all the facts, they look to people like themselves and see what decisions those people have made to guide their own decisions. We talked about things like the health belief model, which separates your perceived susceptibility from the perceived severity of any particular disease condition. And so we had, I think, a very interesting conversation, and the residents took that to the patient, and I think through that process discovered that from his perspective, he thought that he wanted to go back to his home country to reconcile with his family that he'd been estranged from. And he thought that if he started dialysis, he'd never be able to do that. He also talked about how he knew that the hyperkalemia was dangerous, but he didn't believe that dialysis would help him because his mom had started dialysis and died very soon after. Whereas his sister, the doctors had said, oh, you might need dialysis, and she always refused, and she's fine. So we began to unpack from a scientific point of view why he was not amenable to what we thought was a very clear evidence-based intervention. And in the story, you know, we talk a little bit about how we were trying to change his perspective, but at the end of the day, changing our own perspective was what it took to connect with the patient. But the thing that I didn't really put my finger on was that this also had a very important effect on the team. So the team of physicians taking care of this patient was frustrated. People felt frustrated, frankly, by the patient. They knew better than to express that, but there was a lot of exacerbation. You know, the renal fellow said we should get psych to check his capacity because this guy is obviously not thinking correctly. But when we took a lens, a scientific lens on his behavior and the behavior of the system, the team engaged in that scientifically. They looked up those articles. They started to look at the research behind how to interact and communicate with patients. And on rounds the next day, there was a very scientific, non-frustrated approach. And it illustrated to me that being frustrated with the patient's behavior was as absurd as being frustrated with the hyperkalemia itself. And so I guess my proposition, and this is maybe going out on a limb, is that as practicing physicians who exist in an implementing milieu, that the perspectives of implementation science will not only make your patients' lives better, it will make your lives better as well. So let me end there, and perhaps we can have some question and answer.
Elvin, thanks so much for that terrific talk and the specific examples as well that I think really can help inform how all of us take care of patients in the future. I do think we have time for some questions.
So I think the randomized control file that you showed, I think was really quite valuable because a lot of times, like conditions assume that randomized control trials are done in a robust way, and there's clinical, scientific research. Conversely, when there's a negative outcome or something inconclusive, a lot of times randomized control trials lead to us abandoning what might otherwise be understated intervention. This isn't an impossible question to answer, but in your mind, if there were trials that were done in more robust fashion, what percentage of, theoretically evidence-based interventions do you think we abandoned because of poorly designed randomized control trials? And could these be lessons for physicians who are interpreting RCT and publications for them as being essentially, flawless?
Thanks for that question. So I think you raise a really profound and important issue, particularly for implementation. And so in my view, a lot of research is now being done to address implementation problems because people see that implementation problems are the rate limiting factor for improvements in population health. But the danger is when they're not conceived of as implementation science, people put together a bundle of things and then they measure the distal outcomes and they don't look at the sort of meat of the issue, which is the implementation of those things that happen in the middle. And without that measurement, I think a lot of times what you end up with is not you can have a successful trial with a failed intervention if you measure the right things. And I think that a lot of times if we're not measuring the right things, you can have a successful intervention in a failed trial. And I think that happens fairly frequently. I can give you many examples. I am being a little bit bold because I'm repeating Don Berwick's critique of the MERIT trial, which is a similar trial, very large, multi-site, thousands of patients, hundreds of millions of dollars about what I call I forget the the sort of pre-code team, right? So if a patient is not doing well, before you call a code, you have a team go and assess the patient in a dedicated, rapid way. And everybody thought this trial would work because everybody was convinced that these things are useful, this team. But yet they did this huge randomized trial and it had no effect. And so then you're stuck because do you abandon this thing that everybody realizes works, believes works, or do you repeat the study, spend another $100 million? So you're in a conundrum. And in that study like this, like many others, there was not systematic measurement of uptake of the practice, right? And so you don't know whether or not that the rapid response teams didn't have an effect, despite the fact that they were used, or that they were not used correctly and therefore didn't have an effect. So I think this is a really important issue. John Ioannidis, who is sort of a scientific pundit, has published the article that's most cited in PLOS Medicine, and it's called "Why Research." The title of the article is "Why Most Research Findings Are Wrong." And he, like many, focused on, and it's the most cited article in PLOS Medicine. He focused on the idea that that there are false findings, right? That we find things that aren't true. The converse, in my view, is an even bigger problem, which is that we throw away things that work, and that is an enormous problem. And I think we just need to be careful in implementation science, also not to repeat that, because I think the types of strategies that we have in implementation science are susceptible to those problems. But
I'd like to build on what you commented about the merit trial and so forth.
yeah,
And I wonder if some of these efforts in implementation science are to try and come up with that device. In other words, the rapid response being a device that could be propagated out versus an effort to look at the system of the care delivery, how we can alter it to deliver the care actually more cost efficient. I noticed that kind of like the patient care outcomes research institute,
yeah,
you never mentioned the word cost effectiveness in the entire talk. That's good to get that grant from practice. I think that bringing this up is that a small community option will be implemented a hospice program actually. We participated through HCA, very actively involved in ISI, save 100,000 lives. And so we were going to implement rapid response as part of patient program. And then we pulled the data out into the baseline data, what was our cardiac arrest rate. And our cardiac arrest rate was actually below the target that we were supposed to achieve for ISI. We were like, well, what happened? And I brought this up in a meeting, and the critical care physician laughed at me. And he said, "You don't know?" And I said, "No, what do you mean?" And he said, "We implemented the hospital medicine program, which worked 7/24. And then I worked a night shift and I found out why. When I was there, I asked the nurse, "What do you think of the hospital?" She said, "Oh, we love hospitals." I said, "Why?" They don't yell at us. And it was primary care provider, and the nurse would call the primary care provider because they're afraid of it. They yelled at us. And so patients were allowed to hear it. And so we put this system in place to deliver care. And that basically became a rapid response team. So I always wondered about this with that particular study, because I sort of stepped back to think about this. As we try to implement intervention, at the same time we're looking at the system to we alter that as well. Because that's a big area. I think a lot of it is the cost piece of some of these implementation science efforts.
Thanks. I mean, I think you covered a number of things that I think are really important. I mean, I think that one thing that your comments reminded me of is the psychological safety literature, right? And how psychological safety is important for high performance, and being afraid to call, because you get yelled at, is this recipe for a disaster. But I think that it's important for us to think exactly as you suggest about the mechanisms by which certain evidence-based interventions are meant to be implemented, and look at those mechanisms in our research. So one of my favorite papers is Mary Dixon Wood's ex post theory of change for the matching Michigan works, right? So about maybe 15 years ago, checklists were all the rage, right? Everybody was like, okay, we put a checklist in, it's going to solve all our problems. We do it before surgery, we do it the checklist at discharge. And indeed, Peter Provenos and others published a paper in the New England Journal showing remarkable outcomes in Michigan. So then people tried matching Michigan. They tried, okay, now we're going to try to do checklists everywhere. And lo and behold, like the same effects were not seen everywhere. And so what she did was she went back and said, okay, so what actually happened and how did this thing actually work? How do checklists actually work? It's not just that you have a checklist and you mark down the things, it's that the checklist brings together a set of organizational behaviors that have other determinants that determine outcomes. And I think that part of maybe making progress, in my view, in implementation science is to begin to to step away from our susceptibility to silver bullets and to ask ourselves, when you have a checklist, right, the research question is then, how did the checklist work? How did it work in this context? And do I understand how it can and should work in other contexts, right? Rather than the question of how can it work everywhere? I think these are difficult questions for the field, but important ones to address.
Yeah, thanks for that talk. That was wonderful. I think that's every word of every story. I am a baby suspect for you. I'm interested in hearing you talk about it. I'm thinking back to when Dr. Tyler had a conversation with the community director, and she made a comment about, there are health inequities, we need to stop documenting them, start using some stuff, and we something around. And we made the point really early on about NIH funding and how frequently there's more worthy and others from the left arm. When you think about sort of strategizing research strategy, where's the needle for when you sort of stop documenting and when to do something about it. And the type of things that I think about your situation experiment, results that you put up about sort of understanding preferences and team preferences and that kind of thing. I know that's big.
I mean, I think that I think that there are many implementation problems that are ready and ripe for testing with implementation strategies. And I think a lot of strategies have a lot behind them. There's also a lot to be developed, to some extent. I think of strategies maybe that, like in the way that we think of maybe medicines like a couple hundred years ago, that some plant has this effect, but you don't know exactly what about it has that effect. And so you might have different doses, you might end up with different formulations, et cetera. But I think many things are ready for testing. And I think that there are big barriers in science that get in the way of that. So one, and this, I hope this isn't a tangent, but one of the things is that the way science is organized is vertical by disease condition. And you end up repeating many of the same lessons across disease conditions that should really be learned within disease conditions that should really learn across. Karen sent me to a paper yesterday about decision support for use of new heart failure medications. It's interesting, and there's a randomized trial published in the prominent cardiology journal, but there are trials like that for HIV, there's trials like that for malaria, there's trials like that for a gazillion other conditions, right? And when we create guidelines, at what point do we say, okay, well, we need something for asthma, even though there's something for heart failure, HIV, blah, 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 or are we going to position our science to learn across our disease conditions? But I think that there are many issues here. I do think that so very briefly, I think that, some of the motivation for implementation science, I think, is simplified. And when we revisit them, they're more complicated than that. One of them is this idea that I think the disparities issue very much falls into that. I think that many things are not implemented, but many things are. And so, I think that there are opportunities to revisit what it is about those things that puts us in a position to test interventions and strategies that have more immediate results. So, yeah, I'll percolate more on the question because I feel like I didn't quite get there, but.
Alvin, thank you so much.
Very hard question. I